Thank you very much, Daniela, and it's great to be here. That's been a wonderful session so far. Thank you to the speakers for a really very, very stimulating afternoon. Now, I am very conscious that it's just me who's standing between you and a lovely evening, so my apologies for that, but thank you all for being here and for ensuring that I have some company during this talk. Let me start, first of all, with, what have we got here? The title. I've been asked to speak about the use and the importance of standardized metrics when we come to prioritize own mother's milk in the neonatal unit. I'd like to start, however, with my disclosures. I would like you all to be aware that I do not do any nutritional research for commercial companies, that I have been a member of the Nestlé International Scientific Advisory Board from 2018 to 2023, but I have not accepted any personal remuneration for this role. I will receive an honorarium, I believe, and travel and accommodation expenses from Medela for participation in this symposium. And I have been a co-investigator on a study funded by Prolacta, which is a company marketing human milk products. I have a number of current grants from the UK Medical Research Council, the UK National Institute for Health Research, the International Neonatal Consortium, Chiesi, and the UK Department of Health. And in my own practice, I have always used own mother's milk preferentially and routinely, but I also use pasteurized human donor milk, formula, and fortifier on an individualized basis. So this discussion draws upon a virtual roundtable which was facilitated by Medela in October 2021. But it also draws on, and thank you very much, Medela, for bringing various people together to have that roundtable discussion, which was a very stimulating experience indeed. But it also draws on my experience, as Daniela has said, in leading the UK National Neonatal Research Database, which I'll tell you more about in a moment, and also eNewborn, which is an international neonatal research database. And these databases are used for multiple outputs, again, some of which I will speak to you about. But the premise of my talk is that standardized metrics on breastfeeding are very, very powerful tools to improve outcomes for all very preterm and sick newborn babies. Because if you don't measure, then we can't quantify change, we can't quantify our success, and quite frankly, we don't know what we're doing. So metrics and measurement are clearly very, very important indeed. And I have to emphasize, as indeed has been emphasized by every speaker today, that although this is the idealized perception of breastfeeding, this beautiful picture by Picasso, of course the reality for the mothers of babies we have in our neonatal units is something quite different. Sick, full-term babies, very, very immature preterm babies, and of course we all know that milk expression over a prolonged period can be difficult and very stressful. And of course, has been said repeatedly and needs to be said repeatedly again and again and again, own mother's milk is far more than a food, it's a multi-component medicine. And I will highlight a point here, which is one that is absolutely crucial to us as a neonatal community, which is that milk in the big wide world of regulatory affairs is still regarded as a nutrition. And this brings a lot of problems with it, because of course it is, for us, far more than nutrition. It's a multi-component medicine. Anyway, to get back to the issue of metrics, the extent to which babies receive their own mother's milk during their stay in a neonatal unit and the extent to which they're breastfeeding at discharge are important quality of care metrics. Again, that's a point I think that has been stressed by all of our speakers, and I think this audience well accepts. And Sarah's already alluded to the UK Royal College of Paediatrics and Child Health National Neonatal Audit Programme, but I'm going to use this just to emphasize some of the points about what we can do with data and what data tell us. So this figure comes from one of the National Neonatal Audit Programme reports, the last one referring to 2021 data, And it shows here neonatal units, 160, 70 odd neonatal units in England and Wales, showing the receipt of any own mother's milk at discharge. This is babies less than 32 weeks gestation. And you will see here that the rate varies from around 25% for units down here to around 85% here. And it's very useful if you're an individual neonatal unit to know where you stand, because then you know what you can aspire to. So publishing these sorts of data does help, should help, can help individual neonatal units. And remember, this is whole population data. Every single baby born less than 32 weeks gestation in England and Wales features in these data. This is a point that is worth emphasizing. These are not hospital-based data which exclude some babies. These are population-based data because every baby less than 32 weeks gestation in the UK will be cared for in an NHS neonatal unit, and all that data is featured in figures such as this. So this is really, really accurate. We can look at this too. Our care is organized into networks, so we can look at this too as to how we're doing on a network basis. And a network means networks function so that babies move between levels of care within a network, and so a network has a very coordinated approach to the care that it delivers. And so on a network basis, we can also see how the rate varies, and you can see that it varies here from around 50% to around 76%. So networks as well can collectively examine their practices and decide what they need to do to improve. But, as Sarah's also shown this slide before, the fact that we have data, and these data have come from, over the years, have come from the National Neonatal Research Database, we can see that nationally the rate has remained static. So the pale blue bars here show the receipt of any breast milk at discharge home for babies less than 32 weeks gestation, and you can see that this is a flat line. So we do need to understand why we're not improving. Okay, we're not getting worse, but we're not improving. But we don't know why we're not improving, despite a multiplicity of quality improvement programs that have been initiated. So this is an important research uncertainty for us that we really need to address. But at least we know what our baseline is, and we know that since 2013, these are our rates, and they have been static. So when it comes to using data, we can use data for audit and benchmarking, and audit and benchmarking tell us what's happening, but they don't tell us why it's happening. And to understand why we're not improving, we need research, and data can help us with research as well. And to improve, we need quality improvement programs which are predicated on good evidence-based practice, not the imposition of non-evidence-based practice, but the delivery of good evidence-based practice. That's quality improvement programs. And of course, consistent, high-quality, population-based data can help with all of these outcomes. So that's what brings me to the NNRD, the National Neonatal Research Database, and also eNewborn, which I'll come to in a moment. But the UK's National Neonatal Research Database is a wonderful collaborative, collective effort involving every single neonatal unit in England, Wales, and Scotland, and Northern Ireland will be joining by the end of this year, so it will truly be UK-wide. But it was established in 2007. It holds data that is extracted out of electronic patient records, a very standard data set. It's called the neonatal data set, surprisingly. It's an NHS information standard, and every single neonatal unit in the country contributes to this database. It currently has, actually since I made this slide, it now contains over 1.4 million patients. About 100,000 new patients are added each year, and it supports, as I've said, audit, quality improvement, and currently research funded to a total of some £25 million conducted by investigators in the UK and elsewhere in the world. So it's a proven resource. But more recently, I've been privileged to take over the leadership of eNewborn. Now, e-newborn was developed by a friend and colleague, Professor Dominique Aumont, who was a Belgian neonatologist, and she established this as a pan-European benchmarking platform. When Dominique retired, there was a search to find a new home for e-newborn, and ultimately that new home was with us, where it's being it's being managed and supported by my team, who also managed the National Neonatal Research Database. But we've widened its remit so that it will support more than benchmarking. We want it to support all of these other uses that data can be put to. So if you Google e-newborn, and the web link is on this slide here, you will see that we're still very fledgling, but we're growing rapidly. Currently, some 16 or so countries have neonatal units that are contributing to e-newborn. Some are whole country registries, such as Switzerland and Japan, and other countries just have individual neonatal units who are contributing to e-newborn. There is absolutely no charge for contributing to e-newborn at all. Everyone is welcome. The details are on the website, and you can get in touch with me if you have any questions. But what we want to do is to collaboratively create this global effort where we can bring data together from around the world to answer the sorts of questions that are important to our babies and our families. And of course, to do that not only requires collaboration, but it very often requires large data sets if you're going to answer questions reliably. And we plan to use the e-newborn data for all of these sorts of outputs: benchmarking, audit, quality improvement, surveillance, research, and policy development. And one recent example of the ways in which data can be used for policy development, it's a very happy story, this, is that data from our UK National Neonatal Research Database was used by one of our UK departments to make the case for extending parental leave for families who have a baby in intensive care. Government departments need data if they're going to make a policy change, and so the data on numbers of preterm babies, their length of stay, and the costs of stay, the burdens on parents, all came from our database. So I think a really nice example of how you can use data to influence policy as well. Now, the other problem, of course, and we're all here thinking about breastfeeding for preterm babies, but you will all know too that nutritional practice for sick and preterm babies is incredibly variable. And quantifying this variability is an important step in trying to understand what's going on and why we're doing what we're doing, and why you're doing one thing, you're doing another thing, and I'm doing another thing. The reason we're doing different things is because we don't know what the optimal approach is. It's because we lack good evidence for many of the nutritional interventions that we have in neonatal intensive care. So this is just one example, which was published a few years ago now. This was published in 2018. But it simply shows timing and type of first milk feed. And in this radar plot, if you look first of all at the purple line, so each of these spokes represents a neonatal network. We had more networks in those days than we do now. But you can see the purple line represents the proportion of babies who are fed within the first 48 hours after delivery. And you can see that that varies from some 40% here, say, to about almost 80–90% in this network here. You can also see the variation of those who are first fed with their own mother's milk. That's the green line. Quite high here, not so high here. Those who are first fed with formula, and those who are first fed with pasteurized human donor milk. So this gives us a sense of the variation within the country, so we know what our baseline is. But there are other data that tell us about variation, and remember, these are whole population data. So that's the strength of this. Every single baby has been included. This is work that we published in 2021, which shows the proportion of infants born below 29 weeks gestation who receive their own mother's milk, pasteurized donor milk, formula and milk fortified by postnatal age. So if you look at this first figure first on the vertical axis, you will see 0 to 100%. This is the proportion of infants born less than 29 weeks. And the horizontal axis is postnatal age from birth to 25 weeks. And not surprisingly, you can see that neonatal teams work very hard, so that about 80% of babies, and the colored lines represent each individual week of gestational age. 23 weeks, the orange line, 28 weeks, this red line here. So neonatal teams work very hard, and in the first month, about 80% of babies are receiving their own mother's milk. But as expression gets harder and harder and harder, as we all know, that proportion dwindles away. As it dwindles away, the use of formula increases. Again, no surprises here, but you can see that you can drill down into these data and see the individual variation. This third figure shows the use of pasteurized human donor milk, at maximum about 20% in the first couple of weeks, and then dwindling rapidly. And then the last panel shows the use of fortifier. And the use of fortification, by the way, is not standard of care in the UK. So you can see that at maximum, about 40% of babies less than 29 weeks gestation are receiving any fortification of their milk feeds. There are other uses for the National Neonatal Research Database. This is another example. This was a 2-year whole population study using a causal inference analysis technique, asking the question, what are the nutritional antecedents of necrotizing enterocolitis? And this was published in Lancet Gastroenterology, Hepatology in 2017. And what we showed was that the receipt of any own mother's milk in the first 7 days is protective against necrotizing enterocolitis. You'll see an absolute risk difference reduction of minus 0.88%, a relative risk reduction of 0.69. But the really important point for us was that, yes, own mother's milk in the first 7 days is protective, but what it does not do is eliminate risk, because 50% of the babies who developed severe necrotizing enterocolitis leading to surgery or death had only received human milk prior to disease onset. So we need better therapeutic and preventive modalities. And then more recently, of course, as the amount of data that we've assembled has increased, we've been able to get into the AI world. So don't worry about the detail here, but I simply put this plot up to show that with large amounts of data, you can do much more interrogative, detailed analyses. And in this study, we identified clusters of nutritional practices across the UK, and again, using quasi-causal inference techniques, identified what may be causal relationships between particular nutritional practices and particular outcomes. And one such was the receipt of own mother's milk in relation to reduction in bronchopulmonary dysplasia risk. But with larger and larger and larger amounts of data, we will be able to do even more meaningful analyses and data science explorations. And then, of course, most recently of all, we are developing what we've called Collaborate, for obvious reasons. It's about bringing people together to answer questions that are important for our families, which we can only do collectively. So Collaborate is a planned, international, adaptive, precision medicine, randomized control platform trial. It's efficient, it's cost-effective, and it'll be low burden for clinical teams and families, because the majority of data will come out of the National Neonatal Research Database and other similar operational modes. And our initial aim is to evaluate the efficacy and mechanisms of action of interventions to prevent or treat neonatal necrotizing enterocolitis, but also to develop this research infrastructure so that it can be used for other very pressing research issues in newborn care. And we've been delighted to have been supported by EFCNI, the European Foundation for the Care of Newborn Infants, who, for example, helped us to assemble focus groups of parents from across Europe to discuss and to get their views about the methodological approach for this platform. And this, for example, was published in Early Human Development just early this year. Parents are very supportive of research. We know that. They want us to answer questions that have been going on for a very, very long time. And taking part in this focus group was a particularly inspirational event, because it was great to hear their ideas for the ways in which we should be delivering clinical trials. It was great to hear their recommendations about whether we should do it this way or that way or the other way. So I think this was a hugely, hugely stimulating experience indeed, and it gave us some great insights. But just to finish, what about metrics? What about data, you're going to say? Well, if we're going to promote breastfeeding on an individualized neonatal unit-based approach, we really need to move from reactive to more proactive partnerships. And that means taking into account all of these bullet points that you see here, because each of us works in a neonatal unit that's not going to be exactly the same as the next person's. There's the institutional ethos. Do we have champions? There's close contact between mums and babies, and dads and babies, families. Do we really promote this? Do we have family accommodation? Are we good at providing non-judgmental support? Are we good at transitioning to breastfeeds, suckling at the breast? Are we advocating for, are we lobbying for? Many of you will know I say this again and again and again and make no apology for it. Do we have supportive national policies? Do we lobby for good parental leave? It's not fair to a woman to ask her to breastfeed and then make her pay a penalty. Are we honest with our parents about the evidence that we have, and more importantly, the evidence that we don't have? Are we conducting audit? Are we promoting research? So each of those bullet points could occupy a whole seminar. Medela, there's lots of scope for you for work for you in the future. So measure, measure, measure. What you can't measure, you can't improve. But there are challenges with data. Most of us will be collecting data in one way or another in our neonatal units, but we collect data inconsistently. Some of us collect this, some of us collect that. We don't do feed type, feed volume, administration method, for example, consistently. We use different formats. Some of us do it on paper, some of us have electronic patient records. If we do use electronic patient records, our ability to extract data out of those EPR systems is very variable. Many of us don't have good support for actually entering data reliably, so the stuff that goes in, well, we hope it's right, but we don't know that it's right. How many of us actually publish data on how good the quality of our data are, how complete they are, and how available they are? And the analysis that we do, because a lot of us do analyses within hospitals across the world, but these analyses vary. We use variable methodological approaches, and we have very, very variable benchmarking across and within countries. But let me end with a very simple, and this is not a recommendation, this is a point for reflection. Take these 7 bullet points here for minimum data suggestions. Gestational age at birth, the infant age at hours when first given their own mother's milk or colostrum, daily recording of the volume of own mother's milk and volume of other enteral feeds, and then at discharge, is the baby exclusively, partially, or not breastfeeding? At 3 months, is the baby exclusively, partially, or not breastfeeding? And 6 months the same. Now that's not a huge amount of data, but with those simple data points, on the other side of the screen, you can see the metrics that could emerge from this. And those metrics would be incredibly useful. We could calculate the proportion of infants receiving colostrum, their own mother's colostrum, within the first whatever you want, 4, 6, 2, whatever, but within the first period of time. We could calculate the receipt of own mother's milk as a proportion of daily enteral feeds, and most importantly, we could calculate the proportion of infants receiving any or exclusive own mother's milk at these key time points. So we can do a lot if we standardize the variables that we are recording. And this, I think, is something that it would be really, really, really good to do across the globe. But I'm going to end with recent and upcoming developments. First of all, if you're interested, please go to our website, the UK National Neonatal Research Database website. We're starting to put online some interrogative tools so that you can manipulate the data yourself, you can interrogate the data yourself, you can look here, for example, the extent to which the data are complete or incomplete for particular variables, and you can pull out some summary statistics on the basis of, for example, gestational age, sex, and so on and so forth. So please go along and have a play with that and send us your feedback, because we are trying to improve this all the time. Then, of course, many of you will know EFCNI has published their standards of care for newborn infants, in which they refer to the importance of data collection and documentation, and the opportunities that consistency will enable us to audit adherence to standards of care across Europe and ultimately, I hope, across the globe. If you'd like more information about eNewborn, as I say, everyone is welcome to join. There's absolutely no charge for joining at all. This is a collaborative effort which is completely free. Please email me or have a look at our website. And so finally, implementing standardized recording of data about lactation, infant feeding, would really be a very simple, it's not rocket science, a very simple but really important step towards the development of universally accepted quality indicators. But of course, using data effectively has multiple benefits, because that same data point that you've captured, baby's birth weight, baby's gestational age, baby's whatever, can be used for so many other ways in which we can improve patient care. And high quality data collection can therefore really spearhead a leap forward to ensuring that all infants admitted to neonatal units receive their own mother's milk, but also it can improve other aspects of care. So a very low cost, very simple, not rocket science, something we can all do to improve care for our babies. And I believe this picture, this is our Christmas karaoke party from my research group last year, and I put this up because I believe it may have relevance to this evening. Thank you very much indeed.